The connection between low vitamin B3, niacin, and chronic fatigue syndrome, CFS, is both biologically plausible and clinically significant, yet it remains disturbingly underacknowledged in both mainstream and integrative medicine. CFS, also known as myalgic encephalomyelitis, ME/CFS, is characterized by profound, persistent fatigue, cognitive dysfunction, brain fog, post-exertional malaise, and unrefreshing sleep. Despite decades of research, it remains poorly understood and inadequately treated, with most interventions aimed at symptom management rather than addressing the underlying cellular energy dysfunction that appears to drive the condition. And here is where niacin, through its critical role in NAD+ synthesis and mitochondrial health, may offer an overlooked key. At the cellular level, mounting evidence suggests that ME/CFS is fundamentally a disorder of impaired mitochondrial energy metabolism. Numerous studies have documented reduced ADP production, altered oxidative phosphorylation, and increased reliance on anaerobic glycolysis in CFS patients, even at rest. When patients engage in minimal physical or mental effort, their already strained cellular energy systems crash, resulting in the hallmark post-exertional malaise that defines the illness. This is not laziness or depression, it's mitochondrial collapse. And for mitochondria to function properly, they require adequate NAD+, a molecule whose availability is directly dependent on niacin intake and metabolism. NAD+ is a central coenzyme in redox reactions that shuttle electrons through the mitochondrial electron transport chain. Without it, mitochondria cannot produce ADP efficiently. In ME/CFS, studies have shown reduced levels of NAD+ and its metabolites in blood and muscle tissue. Researchers have even proposed that ME/CFS may be a form of systemic NAD+ depletion, where cells operate in a state of bioenergetic distress, unable to meet energy demands or recover from stress. And yet, this insight has not translated into widespread clinical practice. The paradox is striking. Despite clear signs of NAD+ depletion, niacin supplementation, the most straightforward way to restore NAD+, is rarely used in CFS protocols. Instead, treatment remains focused on symptom suppression, sleep aids for insomnia, antidepressants for mood symptoms, stimulants for fatigue, and cognitive behavioral therapy, CBT, as a behavioral patch for what is clearly a metabolic and inflammatory condition. Some patients turn to CoQ10, D-ribose, or carnitine, mitochondrial cofactors that may help, but none of which will work optimally without adequate NAD+. What makes this even more frustrating is that niacin is inexpensive, widely available, and extremely well tolerated in the niacinamide form, which does not cause the flushing associated with high-dose nicotinic acid. Supplementation with niacinamide or other NAD+ precursors can elevate NAD+ levels systemically and support mitochondrial function. In anecdotal reports and small studies, patients with ME/CFS who take B3, especially in combination with other NAD+ precursors or mitochondrial supports, often report improvements in fatigue, cognitive clarity, and recovery from exertion. These reports have yet to gain serious clinical traction, partly due to the lack of large, well-funded trials, but also due to a medical model that is treatment-centered rather than root-cause-oriented. Even when NAD+ is discussed in research circles, the focus tends to drift toward proprietary NAD+ precursors like nicotinamide riboside, NR, or NMN, nicotinamide mononucleotide, which are expensive and often inaccessible for chronic illness patients. Meanwhile, plain niacinamide, which is cheaper, readily available, and proven to increase NAD+, is brushed aside, despite its practical utility. This reflects not only a scientific oversight but a pharmaceutical and economic bias. If it can't be patented, it can't be prioritized. Beyond energy production, niacin also supports DNA repair, reduces oxidative stress, and modulates neuroinflammation, all factors implicated in the pathophysiology of ME/CFS. Inflammatory cytokines like IL-6, TNF-alpha, and interferon gamma have been elevated in CFS cohorts, contributing to brain fog, pain, and fatigue. NAD+ dependent enzymes like sirtuins and PARPs help regulate these inflammatory responses, but they can only function when niacin intake and NAD+ levels are adequate. So, why isn't niacin part of standard CFS treatment protocols? The answer lies in a combination of inertia, incomplete education, and a medical system that too often addresses symptoms in isolation rather than systems in context. Fatigue is treated as a psychological issue or sleep disorder when it may in fact be the body's signal of metabolic insufficiency at the cellular level. Instead of asking, what drug can reduce this symptom, we should be asking, what's broken in this cell's energy engine, and how do we fix it? Niacin is not a cure-all. But for me/CFS patients, it may be a missing link, a low-risk, evidence-aligned intervention that supports the very pathways under collapse in this devastating condition. Restoring NAD+ through appropriate forms of niacin could improve not just fatigue, but resilience, cognitive function, and cellular repair, offering hope where conventional medicine has too often come up short. In the future, the metabolic basis of me/CFS may become fully recognized, and niacin may take its rightful place in both prevention and treatment strategies. Until then, the evidence is clear. Ignoring niacin in the management of chronic fatigue isn't just an oversight, it's a failure to engage with the underlying biology of the illness.